Hello and welcome to our CFN webinar, the pilot study of an automated one-year mortality prediction tool to trigger advanced care planning. Today's webinar I will be hosting. My name is Amanda Lorbergs. I am the manager of research and knowledge translation here at CFN. As per usual, we will have you submit your questions during the webinar using the chat box on the app, and we'll try to answer as many questions as we can during this 1 hour webinar. Just a quick reminder, at the end of the webinar, a survey will pop up on your screen, so we welcome your feedback to let us know how we can improve this webinar series. And as always, these are recorded webinars and should be available on our website within a day or two. A couple of reminders about upcoming webinars. We have one on February 6th, looking at cardiac surgery among the frail and elderly towards optimal decision making. And then on Thursday, February 28th, we have another one, care of acutely ill older persons living with frailty, making healthcare work like a system. So tune in for those coming up. A couple of announcements here at CFN. The knowledge translation competition is now closed, and the successful intent to apply applicants will be notified and invited to submit full applications by the end of the month. And we are happy to announce that the National Conference on Frailty is scheduled for September 26th and 27th, 2019. CFN is working with the Canadian Foundation for Healthcare Improvement and the top 5 showcase winners from last year's conference to explore how we can further spread their innovations. For more details, you can click on that link that you see below. So without further ado, I'll introduce our presenter today. It's Dr. James Downer. He's the head of the Division of Palliative Care in the Department of Medicine at the University of Ottawa. And his clinical time is split between an intensive care unit at Ottawa General Hospital and the palliative care unit at Briere Continuing Care. And I believe we are ready to go, so James, we'll hand it over to you.
Hi guys, am I promoted now? Oh yeah, show my screen.
Yes,
okay,
you
great.
are.
All right, nothing I like more than promotion. Unfortunately, I can't do self-promotion here. Hi everybody, James Downer here, going to be presenting today. I've changed the title ever so slightly just to take account of some subsequent work we've done on this project and really link it into future work in this area. But again, I promise to show you the results of the actual project we did. So without any further ado, we'll just go ahead. No, I don't know. Sorry guys, I can't advance my slide for some reason. Oh, there we go. Sorry, I think I went too far. Okay, hang on. Ah, stop. There we go. Okay, we're gonna do this again. There we go. My disclosures: I've received speaker fees and honoraria from these companies that have nothing to do with anything I'm going to talk about today. I've received no commercial support for this talk. We're going to talk about the importance of timely identification of patients with unmet palliative needs and talk about some of the limitations of current approaches to earlier timely identification in our current system. And then, of course, talking about the project at hand, really newer approaches to overcoming these limitations. I want to acknowledge a number of people who have been involved in this project and very supportive of it from the get-go. And they're acknowledged here on this slide, and I won't go into all of their names, but you can read them, that they've all been, this has definitely been a team effort. And of course, great gratitude to Canadian Frailty Network for funding this research now a couple of times, to CFHI for funding and supporting, and we won a National Innovation Award in Palliative Care in 2017 for this, and of course the AMS Phoenix Fellowship that's been supporting this work as well. So again, a team sport. You know, there are a lot of different scary statistics and slides that you can use to demonstrate some of the gaps in end-of-life care and palliative care in Canada. This is probably my favorite of the past year. So Sen Xiao and Peter Tanasaputro put out this study, and I'm going to pluck out table 4, which basically shows who is receiving palliative care in Ontario. There are 3 columns indicated. Terminal illness, these are essentially patients dying of cancer. Organ failure, which are patients dying of generally a single organ failure. And then frailty, which is kind of a age-related multimorbidity, frailty, catch-all group. As you can see, roughly the same number of people die following each trajectory, but there is a real difference in terms of the kind of palliative care they receive based on billing codes. So if you're dying of terminal illness here, you'll see on the column on the left, 88% do receive something that is coded as palliative care prior to their death. And of those, 2/3 are receiving it in the community. Their first receipt of something called palliative care happens about 107 days, so 3.5 months before they die. And they get something coded as palliative care 1 in 3 days between then and the time that they die. And even the lowest quartile is still getting palliative care about a month or a little over a month, starts to receive it a little over a month before they die. So those aren't actually terrible numbers. I mean, you could probably do a little bit better, and we can talk about the methodological issues with how this receipt of palliative care was assessed. But compare and contrast the other 2 trajectories. Organ failure, where instead of 88%, it's now 44%. And in terms of receiving it in the community, instead of 2/3 of patients, it's actually only about 1/6 of patients. Instead of getting it 3 months before you die, you get it 3 weeks before you die. And to add insult to injury, instead of getting it every 3 days or more than every 3 days, you're getting it every 4 days. And frailty is even worse than that. So again, a real stark contrast between those dying of cancer and those dying of non-cancer conditions. And if you think about how we're going to start to close this gap and improve these transitions of care and make sure that people with non-cancer illness and frailty are going to be getting, or I should say, if we're improving palliative care and end-of-life care for all Ontarians and all Canadians, it's clear where our efforts need to lie. And a lot of this has to do with earlier provision of services, more reliable provision of services, particularly among those with organ failure and frailty. Whoops. Early identification obviously is very important. It's been highlighted by the Ontario Palliative Care Network. The values have been shown, and I'm not going to go into great detail in them here. It was featured in the Declaration of Partnership, which is an important landmark in palliative care in Ontario, Provincial Roundtable Report of 2016, again highlighting the importance of early identification. The OPCN was created, and one of its mandates, Action Item C, enabling early identification of people who would benefit from hospice and palliative care. And just this past year, Health Quality in Ontario released their palliative care quality standards, and statement number 1, reliable identification and assessments of patients with unmet palliative needs. Certainly a lot of the evidence around the early provision of palliative care, and I think there are, a lot of people raising appropriate methodological concerns or challenges in interpreting some of this data. But certainly many are familiar with this RCT of early palliative care in lung cancer, highlighting the benefits of early palliative care. Sorry guys, having a little bit of trouble with my, whoops. We'll just go right back to that. Talk amongst yourselves. All right. And we're back. So that's early palliative care. And then in Toronto, Camilla Zimmerman leading a sort of single center, multi-clinic cluster randomized control trial. Although the primary endpoint was negative, some secondary endpoints did show improvements in outcomes and quality of life and symptom scores for early palliative care. As a result of these RCTs, you'll see that the ASCO guidelines for the management of patients with cancer, showing this combined standard oncology care and palliative care in 2012 said they should be considered early in the course of illness. In light of these studies and these results, upgraded their recommendation to should receive dedicated palliative care services early in the disease course. And that's all great. The problem is, of course, this notion of early. Early is actually not a specific time, and trying to decide where on the continuum of illness as people approach the end of their life early actually is more than a trivial point. So this is the bow tie model, replacing these slippery wedge models of yesteryear. Pippa Hawley has published this, and I'm a big fan of this model because I think it really captures the different ranges of options and directions that people can take as they as they get sick and as they get palliative care and as they might recover. Certainly there's this notion that there's early, there's earlier, there's not so early, and then there's early-ish. Other people have highlighted the problem that there actually is such a thing as too early, right? Like, we obviously, aside from any practical consideration of literally referring everyone for early palliative care at the moment of any kind of sinister diagnosis, it's just not feasible, it's not realistic, and probably not beneficial to do that. Others have highlighted an actual, what they call a Goldilocks phenomenon, where there's such a thing as too early referrals, where, for example, if you engage way too early in the disease course, in advanced care planning or goals of care discussions, that people can actually get anchored to a position of I'm a fighter or I want aggressive care done, and actually that undermines subsequent discussions. No, don't worry, we don't need to discuss it, we've already discussed it, he says he wants everything, and that people get stuck on that position even as conditions change. And that's been, I think, described in the literature as well. I feel like I'm about to crash my computer again. Again, not able to. All right, sorry guys, we'll do this all again.
Hi, James.
Hi.
What we can do, we'll throw up your slides on our end, and then you can just let us know when you want us to advance a slide, if that works.
Yeah, do you want to try that, or here? Let me do it one more time. Do you want to just have that ready, because I'm up and running? Sure. So.
Sounds good.
Yeah. Okay. So. The problem, of course, is that everybody will tell you after someone dies that in retrospect, geez, you know, we really should have done that sooner. We really should have called palliative care sooner, or this was a way too late transition. It's a lot like telling somebody that they burned toast. You usually don't have to tell people that they burned toast, you know, and then the subsequently even more useless comment is that, you know, you really shouldn't have left that bread in the toaster quite so long. You know, I don't think it comes as a great shock to anybody that the reason they burned the toast is that they left the toast in the toaster too long. The challenge isn't deciding in retrospect that you put the toast in the toaster too long. The challenge is identifying in advance when you need to take the toast out of the toaster. Toasters are built with timers. Humans are not. This lovely poem from Piet Hein highlighting this sort of silly notion that we get into here. Obviously, defining when somebody is palliative or what palliative care actually is really challenging. And even in a research setting, there have been a number of studies highlighting that we really just don't have any consistent definition. People are very vague. Even in published RCTs that hopefully would have actually defined this well, there are very few that have clearly defined what their palliative care interventions are or definition of their patients. There's a lack of consensus concerning the attributes of illnesses that need palliation, ambiguous use of the adjective palliative, and this is quite recent. In practice, many of us, when we trigger palliative care or palliative care referral, it's often in response to an event, right? So either the development of a characteristic that we know to be associated with a short prognosis, right? The masses are growing, the functional decline is another one, or sometimes they've just suddenly been handed a really horrible advanced diagnosis that we know to be incurable. And those are what usually prompt us to then start to consider if this person has unmet palliative needs, and we move on from there to actually review their care planning and current care. So really, how good are we at prognosticating? The problem with using prognostic-associated triggers for this reflective process is that our ability to prognosticate is really poor. This is a study reviewing a number of different models, and some of them are quite complicated, of trying to identify patients with medical illness who are, nearing the end of their life or predicting risk of death. And you'll see in the column I've highlighted here the C statistic. And for those of you not familiar with C statistics, these are numbers that range generally from 0.5 to 1.0, 0.5 being the worst accuracy, like a coin flip, and 1.0 being perfect discrimination between those who are dying and those who are not. Numbers that end up in the sort of 0.6, 0.7 range are not helpful. Low 0.8 is still minimally helpful at best. And these are often very complicated models where it's take a long time to sit down and actually puzzle this out. I'm going to talk about the HOMR model at the bottom later, but you can see that our existing prognostic models just not that good. We often use functional impairment and, more to the point, functional decline, like the trajectory of decline as our trigger, and that's used very commonly in palliative care. Here's the problem with using that model. So this is a really nice publication from Jontino, looking at, in the 12 months leading up to death, so going from left to right on this curve, you can see a number of different illness trajectories. The ADL score is the y-axis, so that's the number of activities of daily living that the person needs help with. Any score below 1 is a functionally independent person. Any score above 1 is essentially a dependent person. So you can see that the cancer, which is the diamonds with the dotted line at the bottom, starts off at the bottom. Patients are independent, independent, independent. And then right around 4 months prior to their death, they flip over into the dependent range on average. And you see quite a pronounced inflection point around 3 months. Not surprisingly, and not coincidentally, the normal time for many palliative care services to accept patients is a prognosis of 3 months. And as you can see, it just corresponds very beautifully with the trajectory seen in cancer. This is usually when people start to need their supportive services, and they need them quite intensely in the final 3 months of life, but didn't usually in the previous 9. The only problem with this is literally every other disease trajectory does not follow this pattern. So the patients with every other condition, stroke, COPD, diabetes, CHF, on this chart, you can see that their ADL score was at 12 months prior to death was exactly the same as what the cancer patients had at only 3 months prior to death. So, but of course they're not eligible at 12 months prior to death, and they've had these high level of needs throughout the final year of their life and probably beyond that. So not only do they start off high, but they actually don't change that quickly. So that transition, that trajectory, that inflection point that's very easy to notice in cancer care, well, you don't really get it in any other condition. So again, highlighting another major reason why a lot of you saw that what you saw on the first slide, which is that distinction between cancer and non-cancer. Okay. Shoot. Okay. Should we go to the backup plan here, guys?
Yeah, we got you here.
Thanks. But at least I paid a lot for Office 365. That's the important part, and I'm sure their tech support will tell me that it was nothing to do with them. Okay. Thank you. So, okay, can you advance to the next slide here? So trying to integrate this, a lot of people have advocated for the use of what's called the gold standards framework or prognosticator gold standards framework / prognostic indicator guidance, or GSF-PIG tool, which is a 3-tiered question. You start with the surprise question: would you be surprised if this patient died in the next 12 months? Now that's a kind of a gestalt prognosis question, but it turns around the notion of, do you think this person is likely to die? Do you think this is kind of possible? Right? Not what is probable, but what is possible. You follow that up with if you would be surprised, in other words, you don't think they're in the final year of their life, you move on to what are called general indicators of decline and specific clinical indicators. This has been pretty widely advocated around many parts of the world until recently, and I just want to talk a little bit about these 3 now. So can you advance to the next slide? The problem with the surprise question, frankly, for those of us in, frankly, I just don't feel like I could be surprised by anything anymore. But the data around the surprise question is actually not that good. It doesn't suggest that it serves a particularly good role for the purpose intended here, right? So take this meta-analysis, 16 studies, 11,000 patients, and what we found for the surprise question. Again, if you're using it as a screening test for patients who might be approaching the end of life, right off the bat, you've got a sensitivity of 67%, right? So as a screening test go, a sensitivity of 67% is a very, very bad number to see. You want to see high sensitivity for your screening test, not low. But then when you combine sensitivity plus specificity and you sort of integrate them into what are commonly used to determine the operating characteristics or the usefulness of a test in what are called likelihood ratios, you look for positive likelihood ratios and negative likelihood ratios. Without getting into the details, generally speaking, a useful test for ruling in a condition would have a high likelihood ratio of 4 or greater. Tests that are useful for ruling out conditions would tend to have a low likelihood, negative likelihood ratio of like 0.25 or lower. And as you can see, both the positive and negative likelihood ratios of the surprise question, overall, neither of those really meet the threshold that we usually associate with a useful test. in terms of positive predictive value, also 37%. So that means that of the patients you flag as positive, only a third of them are actually in the final year of their life. So on the one hand, you have not a great sensitivity. You're fully missing a third of the dying. And 2/3 of those you flag aren't actually dying, certainly not in the next year. Now, again, the surprise question came out of the cancer world. Not surprisingly, you see different performances in cancer and non-cancer. So in fact, when you look at it solely in the cancer studies, the positive likelihood ratio tips just above 4, suggesting that it might be useful for ruling in mortality just among cancer patients. But then when you isolate the non-cancer patients, you get even worse numbers, right? So likelihood ratios of positive likelihood ratios of 2, negative likelihood ratios of 0.5, not a useful test. Next slide, please. There are a lot of other problems with the surprise question, which is that the kappa scores, right? So if you ask 2 people the same question about the same patient, you don't get the same result. In fact, the kappa scores are so low in some studies to suggest that you know, the variability you see in these responses, like the answers that you get, may have as much to do with the physician and the physician's personality as they do with any physical characteristic of the patient, right? The joke is, of course, that it's not so much a prognostic test as it is a personality test. Also, when you do a single center study of 2 or 3 providers in a clinic with a research assistant poking and prodding you in the ribs and reminding you to answer the surprise question for the purpose of the study, you get certainly a pretty good response rate. When you start to farm this out to large practices, family practices, etc., you start to see the response rate drop off dramatically. And we've seen that in a number of studies out of the UK and unpublished data from Integrate here in Ontario. As a screening tool as well, in Spain, you get numbers that are quite stunning. So in some cohorts where they're using the GSF and their version of the GSF, which is known as NECPAL, which includes prognostic indicator guidance and the surprise question, you're seeing about 80% of the patients you screen flagging positive. Well, it's not much of a screening tool if basically 83% of the time you're returning a positive result. You might as well not bother. You're basically flagging everybody. And in results, in light of a lot of this data, actually now in the UK, the surprise question, for example, has been dropped entirely as a screening tool, a recommended screening tool for looking at patients who might have unmet palliative needs. And it was dropped some years ago from the SPIC tool, which also comes out of the UK. Can I have the next slide, please? Practical concerns about using it in the frail. So this is a qualitative study looking at this, and GPs with a lot of frail elderly in their practices did not appear to use the surprise question, despite the fact that they were told to do so. They expressed concerns regarding its use to facilitate discussions. They highlight the subjective nature of the surprise question and potential barriers to conducting discussions. Next slide, please. And again, here's a story out of the Telegraph after a blue ribbon panel basically recommended that the surprise question be dropped. I don't love this title. I think the Telegraph kind of got the title wrong, but worth reading the article because you can actually read what they're saying about it. Next slide, please. So then, if you drop the surprise question, which is really the simple question, you don't really require a lot of training in whether or not you're surprised. It's kind of all gestalt, and it's pretty easy to do. I mean, there really isn't, frankly, anything more simple than a single item gestalt question. But then you're asked to move on to these sort of general indicators of decline and specific clinical indicators, and there's actually 74 of them, right? So asking somebody to literally screen or go through, you know, even a subset of these 74, I think you start to recognize some of the challenges here, which is that this is a lot to ask people to remember to do spontaneously without reminders as part of a busy clinical practice. It's not surprising that the uptake can sometimes be not that good. So next slide. Let's take a step back. What is it that we're trying to achieve with our sort of alerting systems or screening systems to flag people with unmet needs? Really, what it boils down to is a sort of, to use a medical analogy, the afferent limb and the efferent limb, like a reflex arc. So you start off with a patient and family. You want to identify and assess those who you think might have unmet palliative needs, and identify, using identification and assessment techniques, those who have unmet palliative needs. Once the healthcare providers become aware of that, those people can then start to perform interventions, right? You carry out the action and the planning. What do we do about it, right? And these are kind of two separate processes, right? So the GSF PIG, surprise question, all of these tools are really designed as identification assessment to do the afferent limb parts. Next slide, please. What are the barriers to this? Well, there are a lot of barriers that exist in real life, right? So if you're asking people to identify routinely and assess people, well, for overwhelmed healthcare providers, they're just not going to do it, right? Some of them are unskilled, they don't have the training, they don't know how to identify those. Maybe they're unwilling, they think this is all silly, and they don't believe in palliative care, so they're just not bought into the whole thing. Or perhaps they're using inaccurate tools like the surprise question that's just not flagging the right people for them. So all of those barriers can exist. As you can see, there are many other barriers to the actual action and planning, like, again, being overwhelmed or unskilled at intervening. Sometimes the patient and family are unreceptive, or they misunderstand what you're trying to do. And sometimes you have a great plan but no resources, so it doesn't really make any difference to the patient because nothing actually happens. Or you come up with great plans, you try to trigger the resources, but the person taking over care, for example, in primary care or elsewhere, is unaware of this plan, and the whole thing falls apart. But if you look at some facilitators just of the identification and assessment process here on the right, to the degree as much as possible, if you can use a streamlined process that leverages existing workflow, creating a manageable workload. The last thing you want to be telling people is to do everything for everyone, That is not a success strategy. People see way too many patients, people have way too much to do to embark on a very deep and involved process for literally every one of their patients. And when you create self-triggered processes for people who are overworked, they have a disincentive to flag patients, Because every time they flag somebody, they've just increased their workload. So again, you probably don't want to leverage that kind of a process. You probably want to try to create something that's more streamlined using existing workflow that creates a manageable workload for these people. Can I have the next slide, please? So that's where, okay, so in an ideal state, it would be really good if you had a tool that was fairly accurate, Like I take the point that the surprise question was never meant to be an accurate predictor of mortality, but if we're using it as a trigger for processes to identify those who may have palliative needs, a really low accuracy is a bad thing, There is a cost to false positives, We don't have unlimited palliative resources, we don't have unlimited time, and people do get a lot of alert fatigue. So flagging everybody and their dog is not a good strategy for making people actually change their behavior, Eventually they just tune it out. And of course there is a cost to false negatives, If you don't pick up enough people, there are people who are going to have untreated suffering, So accuracy is not a trivial point here. But again, also taking the dependent portion away from the provider, If it's the provider that triggers this, they have a strong disincentive to trigger it subconsciously, because every time you flag a patient, it's workload for you, And we know that individual providers are unreliable. There's very good data on that. So to what degree can we seamlessly integrate this process with our current workflow, using administrative data, using data that's already being collected that we might be able to build around, So next slide, please. This is where the HOMR comes in, So the HOMR is a predictive mortality prediction tool developed by Carl van Walraven here in Ottawa using ICE's data. It's the hospital one-year mortality risk score, and it actually turns out to be probably the most accurate prognostic tool ever developed. See statistics getting up into the low 0.9s, so very, very accurate. Externally validated in outside of Ontario, and it uses really simple administrative data, It spits out a numerical score also. It doesn't give you a yes, no, it gives you a numerical score. So what that does is enables you to actually set the threshold for your response. So say you've got a response that's really resource intensive and you can't do it very often, well, maybe you want to set the bar a little higher, Make it very much more specific so that you don't get too many positives, you don't overwhelm your system. Or if you have a much more scalable resource or a lower patient volume, for example, and you have the ability to really dig in for a lot of these patients or apply an intervention to a lot of patients, well, then turn the threshold down, Turn up your output, and you can basically set the output wherever you think you can manage it. Next slide. So here's what goes into HOMR, So there are actually 3 variations of HOMR, and you can just see they're very simple data points, So the original score was age, sex, whether they're on home oxygen, admitting diagnosis, the Charlson Index, what service admitted them, whether it was an urgent readmission or whether they've had emerge visits in the past 12 months, did they come in by ambulance in the past 12 months, what's their living status, like where did they come from, was home or long-term care, did they get admitted urgently, and did they go directly to the ICU. So if you actually look at what's being collected routinely at admission for every hospital in Ontario, go to the next column for HOMR. We don't routinely enter into the data into any electronic medical record whether they're on home oxygen. The admitting diagnosis actually is only decided by coders at the time of discharge, so we don't have that. And we don't routinely have Charleston. Charleston's certainly not coded at the time of admission unless a person's had a previous admission. But if you take out those three things, i.e. you take out every clinical piece of information that you know about the person, turns out it's still a really accurate predictor, which tells you a lot about big data and how mortality can be predicted solely on simple aspects of behavior. Like, it doesn't really matter what's wrong with you if you're of a certain age and you're coming in multiple times to hospital, getting admitted to medicine, and have come in with readmissions. It almost doesn't matter whether you have cancer, heart failure, COPD, or frailty. You're not doing well, and you are likely to be nearing the end of your life, right? And that's what HOMR proves. HOMR now is a sort of newer version which is designed specifically to be using data that might be available in the EMR. So if they have Charleston coded from a previous admission, most hospitals have that stored in their data warehouses. And then, of course, there was no clinical information, no lab data in the original versions. If you integrate that in, and this has now been published, but actually does seem to be a little bit more accurate and can be run in real time. Next slide, please. So again, it's an invisible process. All the data you need for HOMR is already being entered by admission, by ward clerks or admitting clerks at the time of admission. It doesn't involve anyone doing anything differently than they're already doing. Of course, I talked about already the adjustable threshold. It's obviously auditable, it's objective, and it's prospective, right? So again, it is a prospective clinical surveillance tool. It objectively identifies a pool of patients or a cohort of patients that you can then follow, and you can use this essentially to hang almost any intervention on that you might want. So it's been used in some cases to trigger clinical responses from the admitting team. It might also be used in a study, and it's been used in some studies to be the actual, to flag eligible patients to get an ACP intervention, right? So it's pretty versatile in that way. Can I have the next slide, please? So when we used it in our original pilot study, we decided we'd start small, go with a smaller number of triggers and a number of patients being flagged. We wanted to go for a high specificity, lower sensitivity, right? So we'd set the numbers where we got a likelihood ratio, a positive likelihood ratio of almost 6, negative likelihood ratio of 0.4. So again, if it flags positive, that person's very likely to be in the final year of their life. If it doesn't flag positive, you get usual care, you get no flag, doesn't matter. It doesn't mean you're not going to die, and that's fine, nothing happens anyway. You're flagging at this threshold kind of around 12–13% of patients being admitted, and many of them to medicine, and we did the pilot mostly on the medicine service. And just qualitative results I can sort of summarize. There was actually quite a lot of enthusiasm from staff initially, although they were concerned about getting a lot of alerts, and alert fatigue definitely was something that was fed back after a certain point. We were really worried patients might be worried, like, you know, is Big Brother going to tell people not to treat me, and am I going to get substandard care if I get flagged by the system? Actually, patients were not particularly concerned about that at all. Their response was, hey, anything that'll encourage the doctor to talk to me is a good thing. Next slide, please. Or next slide, please. So again, we had 2 different sites where we were doing this. At one of the sites where we trialed it, we were actually able to integrate it into their sign-out tool. So they had a communication tool that nurses would use to communicate with each other, and that the teams would use to generate their patient lists in the morning. So if there was a flag, it would actually appear to them while they were working in the clinical environment. At the other site, unfortunately, we couldn't do this. So what we did was we ended up sending automated emails to the MRPs. And here's what we saw. So again, the kinds of patients that were flagging, right, about 80%, they're on average in their 80s. They're staying about a week in hospital, a little bit less. A number of them did have limitations in CPR orders at the time of admission, right? So sort of 40% already had. But many of them didn't have really any sort of documented discussion about goals of care, certainly not early in the course of their care, and very few had palliative care referrals. And what we found was when we in phase 1, when we just observed patients at these high risks, and then phase 2, we turned on these notifications, that at site 1, when we integrated the notifications, there was actually a significant increase in the number of patients that did start to get early documented goals of care discussions and or a palliative care consult, and that was significant. Now, I caution you, this was not powered to test for this. It was a pilot study. We're looking at feasibility and acceptability, not effectiveness. And again, this by itself, it's just a trigger tool. It's not meant to be effective, but that was kind of an interesting finding. Also notable is that about 90% of the patients we flagged didn't die during their admission, right? 90% actually survived the discharge. And that's important because, again, it's totally useless to develop a tool that identifies the dying within 2 days of their death. That's way too late. You want to be identifying people when there's still a window to intervene and change things. And the other interesting thing is when you look at who they identified, more than half of those, so dividing it again into those 3 trajectories, the cancer, organ failure, and frailty, more than half had frailty. And only the minority had cancer. So if you look at normal referrals to a palliative care service, for example, 70–80% are going to have cancer, and almost very, very few are going to have frailty. So the nice thing about this is, again, you don't want to develop a tool that basically does what you're already doing automatically anyway. This is a tool that preferentially flags people that we are actually pretty bad at identifying. So it helps us. It's strong where we are weak. Next page, or slide. Qualitative results, again, is sort of people saying they found the prompts helpful. Others felt sometimes they were redundant or too frequent. As long as it's not mandated, it's a good thing. Other people saying it would be most useful if it gave me information I wasn't aware of. If there was a patient I didn't think was at risk, and this tells me they have a high risk of dying, that might alter my approach. Again, so sometimes it was telling people stuff they already knew. It was very funny because during the study, these were automated notifications, mind you. And what was funny is sometimes people, I don't think they knew that they were automated notifications, so they'd send back responses like, tell me something I don't know. Which I thought was kind of funny. And again, the patient's hoping that that HOMR would prompt more communication, particularly for people who are not able to advocate for themselves. Next slide. So again, we moved on from there to a second project, also funded by CFN, and we're very grateful for this, where we said, okay, look, this was just to see if it was feasible. But then again, the question, like, just because you're dying doesn't mean you have palliative care needs, right? Like unmet needs. And we had selected a fairly arbitrary cutoff. Was there anything magical about that cutoff point of the mortality risk that gave that sensitivity and specificity, right? So what we did was we did a second study where we started to survey patients, and we're still wrapping this study up, but surveying patients who were identified by the HOMR tool, and to see how many of them had a symptom score in the severe range, so 7 to 10 out of 10. In one of 9 domains that are commonly used as a screening tool for severe symptoms in the palliative world. And we also used Rebecca Sidori's ACP engagement tool to see what proportion of those flagged were actually willing to and keen to engage with the physician or member of the healthcare team to talk about advanced care planning. Now, again, we also then tried at 2 different thresholds. So we said, okay, let's see if we get different results when we use the higher threshold versus the lower threshold. Next slide, please. So again, what was interesting is and in discussing the approach with the REB, they approved us to do a sort of cold approach without necessarily getting an invitation from a clinical team member. And of those, just walking in cold, 76% agreed to complete the questionnaire. So again, I thought that was a very high number, right? Very, very acceptable for people to be approached in this manner, just asking, questions about their symptoms or their desire to engage in goals of care discussions. In most cases, we could talk to the patient themselves, sometimes to family or substitute decision makers. And it took us about 10 weeks to complete the study on a general internal medicine board. As you can see, and not surprisingly, when you use the higher threshold, you were able to pick up about 8.5% of admissions and screen them. When you use the lower threshold, it was actually a little over 20% of admissions then that you were starting to be able to approach and then get the data on. Again, depending on the trajectory, you would identify slightly different patients. Again, the lower the threshold, the more likely you were to get cancer patients as opposed to the frail. The higher the threshold, the more likely you were to get the frail. Next slide. Drum roll, please. Here's what we found. So when you actually flag people with HOMR, turns out that the prevalence of severe symptoms is pretty high. So at the higher threshold, we're using 77% of patients had 1 or more severe symptoms on their ESATs. And even at the lower threshold, about 62%. And when you then move to assess their desire to engage in advanced care planning, that was pretty high too, so 74%. And oddly enough, with the lower HOMR score, it's actually higher, about 82%. And then if you said, okay, either of those, either or both, 90% or more, regardless of the threshold of people flagged by HOMR, either had a severe symptom, a desire to speak about advanced care planning, or both. So not only is people at risk of death, but they also seem to very often have unmet needs. Next slide. So, and Pete Weger made this beautiful icon array, which was far beyond my artistic skills. But it highlights what this might look like in practice, right? So look at the bottom screen first, right? So say you don't have a ton of time and energy and resources to devote to improving end-of-life care in your hospital. So here's what happens. For every 100 admissions to GIM, if you set the higher threshold, you'll flag 9 of those patients. Those 9 patients will account for about 60% of the 1-year mortality in this entire cohort would be found in these 9 patients. Of those, the red icon, 1 patient will have a severe symptom score. The blue icon, 1 patient will have a desire to engage in advanced care planning. 6 of those 9 patients will have both, and only 1 of those patients will have neither. So again, it's a pretty good focus of your energy. If you have more resources, obviously the icon array above, you're flagging a lot more patients now, but again, you're seeing similar results, is that all but 1 of the patients you flag will have a severe symptom, a desire to engage in advanced care planning, or both. Next slide, please. And just to highlight that this is now being done potentially in other contexts as well, I just want to give a shout out to Peter Tanasaputro and Doug Manuel and Amy Sue and their work here in developing a tool that would be using data from other contexts. So now Peter was using data now from the RAI database, looking at home care data that can be applied either to patients getting care in the home setting or in long-term care, and it's called the RESPECT tool. That's also pretty good at predicting those who are nearing in the final sort of 6-12 months of their life. And again, the opportunity to basically apply the same framework, the same concept, but instead of just, I mean, HOMR is obviously restricted to acute care because that's when the data, that's where that data exists, that's where that model was generated. But you can see now very quickly that anytime you have enough data to build a model in any context, you can basically apply the same framework, right? Oh, can I have next slide, please? So again, what does HOMR now and RESPECT and all these various tools do is it really helps you jump the barriers to the identification and assessment branch of your sort of your approach to improving end-of-life care, right? So it uses these sort of streamlined existing workflow, creating a manageable workload because you set the threshold that you're ready to respond to, and it helps flag these patients. Now again, and then you can hang any number of different interventions on it, right? And I've just put a few on here just to give an example of interventions that might help overcome specific barriers, right? So if your healthcare providers are not skilled at communication and treatment, train them up. Use things like the Serious Illness Conversation Program, develop symptom protocols. Sometimes you can use palliative care consultation, but that shouldn't be, I think, the default pathway. If the patients and family members are having problems with that they're not understanding what you're about or they're unreceptive to the message, maybe some decision aids might be helpful for them. If the plan's not being communicated, use a durable record. But again, all of this can be hung on and built upon the framework of these automated identification tools, right? Because every time you study one of these interventions in a research study, right, you have research staff who do this job. There are people who screen charts. They flag patients. They do this automatically, right? So you can study this and show how effective it is when someone's being identified for you. But it's when you take that outside of the study, there's no research staff to flag those patients, that's where a lot of these interventions might start, the real world effectiveness starts to drop. And that's what tools like HOMR Now and RESPECT can be very helpful for, not only objectively identifying patients, but doing so in a reliable and automated way so that you can go a little further towards replicating the findings that you might have seen in a study. Next slide, please. The key point, of course, is that there's no magic bullet, right? So trying to just study HOMR in an RCT to show improvements in end-of-life care alone, probably not the way to go here, right? Because there are so many barriers, right? Like it's trying to just study one intervention would not make any sense. We did see some improvements in palliative care referral and goals of care conversation, but again, just doing one simple thing and expecting a big effect downstream is probably a little naive and optimistic based on all the other published evidence out there. And of course, there are no assessment or planning systems that can address certain barriers like patients and family resistance or lack of resources, right? Which I think is an important barrier, right? a lot of time where people are frustrated and wondering why we aren't making a big dent in end-of-life experiences of patients. Well, it's got sometimes a lot less to do with how clever our advanced care planning interventions is, and a lot more to do with the fact that people, if they just can't rely on their home care services or support systems at home, then they're still going to use the emergent acute care in order to get the care that they need. And again, as long as we're running around all day with a bucket putting out fires, it's very hard for us to sit down and do rational, patient-centered, time-consuming, but ultimately highly valuable care that we need to do. Next slide, please. So in conclusion from this section, what we found was that the HOMR tool we developed was feasible and acceptable, to be used in this clinical environment. It seems to identify a relatively small number of patients with a high burden of unmet needs, so it can help you focus your limited resources. It also preferentially identifies neglected groups, and in this case, very good at identifying the frail, which we are very bad at paying attention to their end-of-life care needs. It is versatile. You can adjust it based on your capacity to handle referrals. It is possibly effective for changing care alone, although I caution you, this is not what the study was meant to show. It is really, and that alone, this tool is probably not going to do much on its own. No identification system is meant to serve on its own. It's meant to be part of a complete suite of identification and intervention tools. But in terms of future direction, it's a great QI tool to drive any one of these specific interventions, and we've engaged in the process of trying to do that in a number of studies and put in some grant applications to talk about this now, which I'm going to show you. I don't think I can show you on the final slide. Can you click the final slide? Oh yeah, sorry. We're just going to say we're in the process of now submitting. We were submitting a proposal for HQO's Arctic grant, and we were shortlisted, but unfortunately that program's been frozen now, so we're still waiting to hear back, but we're looking at other funding sources to use HOMR to actually drive very specific screening processes. So starting to do what we did in that second study for everybody. Every time you get flagged by HOMR, somebody will go and screen you for unmet palliative needs and document those, hopefully triggering a response. This was also aligning very nicely with HQO's palliative care standard and the newly released QIPs for 2019-2020, which speak to the importance of having reliable and automated, or reliable means of identifying patients who may be at risk of unmet needs and then screening them for those unmet needs and documenting a plan. Again, this is the framework on which we move forward, and we're really hoping that hopefully some of our funders will help us do this project. We've got about 13 large hospitals across Ontario now who are keen to join this project and step up and implement this. And we've got, I think, tech solutions now for multiple EMRs, and we're working on finalizing those, so hopefully it can spread more easily. Because once you get it going, it hopefully runs on its own. So that's all I was going to say today, and I want to thank you very much for your attention. Apologies for the technical problems, and happy to take any questions or be part of any discussion.
Great, thank you very much for the fantastic talk. We do have some questions coming in. Let's start with one. What are the barriers to high quality end-of-life care that can't be overcome by an automated identification tool?
Yeah, so again, as I kind of, you roll it back a couple of slides, we're going to talk about that, which is that, it's not, the same way that identifying any one specific intervention, an intervention doesn't help improve end-of-life care if no one's using it. If patients aren't being flagged and identified that can benefit from it, right? By the same token, an identification tool is not particularly helpful if you're not doing anything about it, right? So just identifying a problem without doing anything about it is pointless. So again, you have to view this as, one of the big barriers being limitations in interventions, limitations in resources to intervene. But then, of course, palliative care is not like other interventions, right? So you can study aspirin or thrombolysis for an MI, for example. And people don't have to necessarily buy into the effectiveness of thrombolysis. Like, thrombolysis will be just as effective in a person who doesn't believe in thrombolysis as it is in somebody who does believe in thrombolysis. You just give the thrombolysis, as long as they consent to it, it'll be just as effective. In palliative care, you actually need patient buy-in. You need family buy-in. We've all had experiences in palliative care where you go and intervene, you sit down with somebody for an hour, they listen to you politely, they ask all the right questions, they smile and nod, but for whatever reason, they just weren't convinced by what you were trying to do here. and they didn't feel that it was relevant to them, and they won't do anything about it because they still feel like they're not at that stage in their life. They don't really feel like taking symptom control medication for whatever reason. They feel it might be harmful, or that they don't have any symptoms that would benefit from it. And more to the point, they're interested in cure and talking only about cure and not talking about palliation. And we've all had those experiences. So in that type of situation, it's very hard to see how any kind of identification system is really going to be helpful there, right? So again, this is a very useful tool for overcoming a number of barriers, a number of very important barriers, but by itself, no tool, no intervention, no identification system could overcome all barriers.
Great. We have a couple more questions rolling in here. Given the constant tension between using prognosis and symptoms or quality of life as triggers for unmet palliative needs, do estimates of prognosis correlate to symptom burden, quality of life, or palliative needs?
Yeah, so great question. Based on our data from this study so far, and we're still collecting data from our second site, it would suggest to me that certainly the HOMR score does correlate with severity of symptoms, right? So the higher the HOMR score, the more likely they were to have severe symptoms, and the higher their symptom scores were overall. I didn't show you that data. So yes, kind of. But I guess the issue is you don't want to profile people. I mean, mortality risk is not synonymous with palliative need. Let's be clear about that. But the point of, you have to understand, what is the point of early identification, right? Early identification is not about defining what palliative care is and what palliative care isn't. Early identification is not about deciding who will benefit from a palliative care consultation, specialist consultation. Early identification is about identifying people who wouldn't have otherwise been identified, or would have been identified much, much later because you're being reactive once things have gotten out of hand, and trying to figure out if they've got unmet needs that you should be doing something about, right? We've got a functioning palliative care system now that doesn't use early identification tools in any routine way. The problem is that when you rely on people to just refer as they see fit, you get a whole bunch of cancer patients, and that's about it. And you get people referred very, very late in the game, and long past probably when they've had severe symptoms and a desire to engage. So again, to your point, right? Like the idea behind early identification hasn't really changed the whole time. You're using the tools that you have to try to flag a cohort of people who are at high risk of unmet needs. And a lot of the time, that's just convenience stuff. Those are like everything in the GSF PIG, every single indicator in the GSF PIG is basically a mortality correlate. It's put in there because these are all mortality correlates. And it's once you use the mortality correlates to identify your high risk group, then you move in to assess for their actual symptomatic needs, or the desire to engage in advanced care planning, or perhaps their need for deprescribing or rational prescribing, their need to be assessed for home care support needs, etc. Like that's the kind of thing. So it's like, to some degree, I think this tension is always going to be there. I mean, if we had, at the same time, like, you can't just screen everybody for symptoms. That's just not feasible, because what's going to happen is you're going to get everybody at every stage in life who's going to get symptoms and have symptoms for all sorts of reasons that aren't really appropriate for a palliative context, right? Because most people aren't sort of entering that period of their life where they're willing to engage and see themselves as favoring quality over quantity of life, etc. The normal people who correspond to the palliative population that we follow. So again, you do need to somewhat hone your focus. Your cohort has to be people who are definitely at risk of death in the coming year, or have serious and incurable conditions, and then also the suffering, the symptom scores, right? I'd say I hope that's a good answer for your question about the tensions.
Yeah, that's great. Thanks. Another question here, more of a practical use question. Who's responsible for interpreting the captured data? Is it nurses, physicians, or any healthcare professional working in the acute care setting?
Yeah, it's a great question, and the truth is, because again, one of the things in the prompt is a lot of people were asking us, oh, James, why don't you just tell us what the mortality risk score was? Like, I want to know, is it 25%? Is it 50%? Is it 40%? We were very resistant to that. I do not want to tell, because I think these are population-derived scores, right? So trying to understand what a 41% mortality risk means to an individual, right? Like, it's a binary outcome. You either is dead or you is not dead. You're not 41% dead. So whether it's 41%, 60%, 50%, it's elevated. Is it elevated? And we're saying, we're setting a threshold to say, if it's elevated above this number, it's elevated enough that you should be considering stuff. Because at the end of the day, I'm actually less concerned with what your precise mortality risk is. I'm saying, okay, once you're above a certain mortality risk, then I want to ask myself if you have unmet palliative needs and focus on those needs. And that's kind of the approach there, right? So in terms of who's responsible for responding to the information and what do they do with it, really we try to use to give useful information, actionable information, to sort of say, instead of saying this person's at high mortality risk and now you've got to figure out what to do about it, we sort of say, look, this person is at elevated mortality risk. Can you please go assess them for uncontrolled symptoms, desire to engage in advanced care planning, etc. And ultimately, in different clinical contexts, the person doing that second stage, that assessment, might actually be different. It could be the clinicians. In some cases, you've got a very exuberant palliative care service that might have like a nurse practitioner, a clinician, a specialist who wants to go screen all our people. Sometimes on each ward, you'll have a champion who wants to take this on. Sometimes it's a distributed responsibility and literally everybody can do it. I think the idea is that what you don't want to do is have it fall and just assign this as a new task to the MRP as their job to assess every time. I think you want to work towards a reasonable approach that could engage any number of people based on who's keen to be involved in this, because there are a lot of people who want to do this.
Great, thank you. So being mindful of the time, we have 1 minute left. I did want to let you know there were questions that did not get answered, but I encourage you to email Dr. Downer if you do have these questions that are urgent, and he'll probably try his best and get back to you. So thank you again, and we'll see you for our next webinar, February 6th.
Thanks kindly for your attention, everybody. Take care.